Hello students, today we will discuss intraoperative arrhythmias, narrow complex tachycardia. It is most commonly asked in examination. The definition is it is a regular narrow complex, that means QRS complex is less than 0.12 second duration. Tachycardia arising from above the ventricles. It includes sinus tachycardia, atrial tachycardia, junctional tachycardia, and atrial flutter. Now we will see the presentation. The ECG demonstrate narrow complex tachycardia. Narrow complex means QRS less than 0.12 second with heart rate in between 100 to 300 beats per minute. The presence of normal P wave will indicate sinus tachycardia. Then flutter waves, they are typically rate 300 beats per minute, present in atrial flutter. A 2:1 block is common and it results in a ventricular rate of 150 beats per minute. During junctional tachycardia, the P wave may be hidden behind the QRS complex or they are visible. They are often inverted or of abnormal morphology. Next, a 12-lead ECG taken during sinus rhythm may reveal evidence of an accessory pathway, that is short PR interval, slurred upstroke on R wave, the delta waves. This is the presentation. Then we will see what is the immediate management. In immediate management, if sinus tachycardia, treat underlying causes. Then having excluded sinus tachycardia, attempt vagal maneuver. What is that? That is a carotid sinus massage. Then give adenosine. The adenosine dose is 6 mg by rapid bolus or rapid bolus. It is followed if necessary by up to 3 doses of 12 mg. Adenosine may terminate the arrhythmia or will temporarily slow the ventricular rate, enabling the diagnosis of underlying rhythm. That is, flutter waves may become more visible. You should avoid adenosine in asthmatic patients because the side effects include flushing, dyspnea, and headache. Then if there is cardiovascular compromise, what do you mean by cardiovascular compromise? Systolic blood pressure less than 90 millimeters of mercury, if there is heart failure and heart rate more than 200 beats per minute, and if there is evidence of myocardial ischemia. These are the signs of cardiovascular compromise. Then attempt electrical synchronized cardioversion using 100 joule, 200 joule, 360 joule monophasic shocks or biphasic equivalent that depend on specific defibrillator. If cardioversion is not achieved, give amiodarone, dose 300 mg IV over 10 minutes. Then repeat shock. Follow this with amiodarone 900 mg IV over 23 hours. Then in absence of cardiovascular compromise, there are several options for the drug treatment that will control ventricular rate and may produce cardioversion to a sinus rhythm. The treatment will include injection amiodarone, dose 300 mg IV over 1 hour followed by 900 mg IV over 23 hours. Or you can give esmolol, dose 50 to 200 microgram per kg per minute, or you can give verapamil. The dose of verapamil is 5 to 10 milligram per kg IV. Then we will see subsequent management. In subsequent management, treat the precipitating reversible causes. What are the reversible causes? That include electrolyte abnormalities, hypovolemia, and sepsis. Then look evidence of any accessory pathway. The patients with evidence of an accessory pathway will need referral to the cardiologist. Then we will see the investigations. Which investigations you will do? The electrocardiogram, urea and electrolytes, then ABGs and thyroid function tests can be done. Then what are the risk factors? The risk factors include inadequate anesthesia or analgesia, hypovolemia, hypoxemia, hypercapnia, sepsis. Then supraventricular tachycardia may be caused by atrioventricular accessory pathway causing pre-excitation antidromic arrhythmia, example WPW syndrome. These are the risk factors. Then we will see exclusion. The exclusion criteria will consist of awareness or light anesthesia, check delivery of inhalational or intravenous anesthetic agent to the patient. Next, ventricular tachycardia will cause broad complex QRS complexes. That means QRS complex more than 0.12 second. Then next, fast atrial fibrillation can appear regular, but close inspection of 12-lead ECG should enable the correct diagnosis. Then we will see special consideration. Supraventricular tachycardia associated with aberrant conduction pathways will produce wide complex tachycardias resembling ventricular tachycardia. If patient is severely compromised, the appropriate treatment is for ventricular tachycardia, that is broad complex tachycardia. Then we will see the algorithm. In the algorithm of narrow complex tachycardia, first look for first you will diagnose atrial fibrillation. If it is atrial fibrillation, then along with that go in algorithm of atrial fibrillation. Then if pulse heart rate is more than 250 beats per minute and patient having narrow complex tachycardia, if heart rate more than 250 beats per minute, synchronized DC shock 100 joule, 200 joule, 360 joule or appropriate biphasic energy. Now if narrow complex tachycardia, if not already done, give oxygen, establish IV access, then give vagal maneuver. Caution, if possible, digitalis toxicity, acute ischemia or presence of carotid brute for carotid sinus massage. Then you can give adenosine. Adenosine dose 6 mg rapid bolus injection. If unsuccessful, if necessary, you can give up to 3 doses each of 12 mg every 1 to 2 minutes. Caution, with adenosine in patient with WPW syndrome. Then look for the adverse sign. What are the adverse signs? If systolic blood pressure less than 90, chest pain, heart failure and heart rate more than 200 beats per minute. All these adverse signs are present, then you go for synchronized DC shock 100 joule, 200 joule or 360 joule or equivalent biphasic energy, and if necessary amiodarone 150 mg IV over 10 minutes, then 300 mg over 1 hour and repeat the shock. And if adverse signs are not there, that means systolic blood pressure less than 90, chest pain, heart failure, heart rate more than 200 beats per minute, these signs are absent or no, choose the following drugs. You can give ismolol, that is 40 mg over 1 minute, followed by the infusion of 4 mg per minute. IV injection can be repeated and infusion can be increased incrementally up to 12 mg per minute. Or you can give verapamil, 5 to 10 mg, or you can give amiodarone 300 mg IV over 1 hour, may be repeated once if necessary. Or you can give digoxin, the dose 500 microgram IV over 30 minutes. You can give 2 doses.